We're now going to be talking about otorhinolaryngology. And we're going to begin with neck masses. Let me tell you at the outset, neck masses can be congenital, can be inflammatory, or can be neoplastic. Let me give you a little background, which we eventually repeat as we review this. But a congenital mass is typically seen in a young person. If it typically has been there for years. The family knows there's been a lump there for 3 or 4 or 5 years in this youngster, but nothing had been done about it because it was not symptomatic. Then it gets infected, it bothers the patient, and medical help is sought. That's a congenital. An inflammatory mass in the neck typically has a short history because inflammatory processes that end up producing neck masses are short-lived. They resolve in a short period of time. The history will not be of years or even months of that mass being present. A neoplastic mass, on the other hand, in the neck, will have a history of several months of relentless, continued growth. Let's look at specific examples. A 15-year-old girl has a round 1 cm cystic mass in the middle line of her neck at the level of the hyoid bone. When the mass is palpated at the same time that the tongue is pulled, there seems to be a connection between the two. The mass has been present for at least 10 years, but only recently bothered the patient because it got infected. This is congenital, and furthermore, the location and characteristics tell you this is a thyroglossal duct cyst. We do for this an operation called a cyst trunk operation. We remove the mass, the tract that leads to the base of the tongue, along with the medial segment of the hyoid bone. There are some practitioners who insist that one should ascertain that there is a normal thyroid in the normal location by doing radioisotope scanning before one removes this remnant of thyroid, which conceivably could be in somebody the only thyroid tissue they have. Vignette number 2, an 18-year-old woman has a 4 cm fluctuant round mass on the side of her neck, just beneath and in front of a sternomastoid. She reports that it has been there at least 10 years, although she thinks that it has become somewhat larger in the last year or two. A CT scan shows the mass to be cystic. This is a branchial cleft cyst. Branchial cleft cysts can occur anywhere from in front of the tragus to the base of the neck, but they will always be in front of the sternomastoid. In some cases, there is a telltale sign of physical exam, a little dimple in the skin right above where the mass is, and that's a remnant of the cleft itself. We do surgical resection of these. In vignette number 3, a 6-year-old child has a mushy, fluid-filled mass at the base of the neck that has been noted for several years. The mass is about 6 cm in diameter, occupies most of the supraclavicular area, and seems by physical examination to go deeper into the neck and chest. This is a cystic hygroma. This is a congenital anomaly of the lymphoid tissue, and they indeed often extend down into the mediastinum. So a CT scan should be done to see how deep this goes before a surgical resection is planned. Let us now direct our attention at neck masses that might be inflammatory or neoplastic, and we have to decide which of the two they are. A 22-year-old lady notices an enlarged lymph node in her neck. The node is in the jugular chain, measures 1.5 cm, is not tender, and was discovered by the patient yesterday. The rest of the history and physical examination are unremarkable. Now, statistically, this is most likely an inflammatory mass. If it was discovered yesterday, The only thing we can justifiably do now is a complete history and physical, which was already done. But one would not be justified on doing CAT scans and MRIs and fine needle aspirate and surgical excision, because a node that has been there for 1 day is very likely to be inflammatory and will be gone in a few days. So typically the approach is, after we've done the complete history and physical, reschedule the patient for another check in about 3 weeks and see what has happened to that. If this was indeed an inflammatory mass, 3 weeks from now it'll be gone or much smaller. If 3 weeks from now it's still there, then we better do more investigation. There are some physicians who are very reluctant to do nothing. And so a very common approach to this, not really a scientifically sound approach, but very common, is to put the patient on antibiotics and recheck the patient in 3 weeks. And the important part of that sequence is that the patient will get rechecked in 3 weeks. Now we move to vignette 5. A 22-year-old woman seeks help regarding an enlarged lymph node in her neck. The node is in the jugular chain, measures about 2 cm, is firm, not tender, and was discovered by the patient 6 weeks ago. There is a history of low-grade fever and night sweats for the past 3 weeks. Physical examination reveals enlarged lymph nodes in both axillas and in the left groin. Now this is neoplastic. In fact, let's talk about neoplastic nodes in the neck. If the node in the neck that has been there, like this one, 6 weeks, and hasn't gone away, is in a young person, and even more so, if there are enlarged nodes in other areas, like the other side of the neck, axillas or groins, and the patient has been having night fever and sweat, that's a lymphoma. And we do an FNA to begin with, and often a surgical excision of a node, so the pathologist can really take a good look at that tissue. If, on the other hand, we have a node that hasn't gone away in a few weeks, and that is in the supraclavicular area, typically this represents a metastasis from a primary tumor that is not in the head and neck, but is below the clavicle. Cancer of a lung, cancer of a pancreas, cancer of a stomach, cancer of a testicle that has metastasized here. And finally, the node we see in the neck that has been growing for a few months and not going away is one that is in the jugular chain in an old man who smokes and drinks and has rotten teeth. That is squamous cell carcinoma. The primary is in the mucosa of the head and neck, and the metastasis is there. And we'll talk more about that one when we get to it. So the one we just read, we realize it's a lymphoma. You can begin with an FNA. An FNA, in fact, let's talk for a second about an FNA. Anytime we're dealing with a mass, and we want to know, is that a tumor, is that benign, malignant, whatever, one of the things we can do is an FNA. I know of only 2 contraindications to an FNA. There may be more that I'm not aware of, but I only know of 2. Don't do an FNA of the liver on a patient you think has a hemangioma, because if the patient takes a breath when that needle is there, it will rip open the hemangioma and the patient could bleed to death. And the second no-no is don't do an FNA for a scrotal mass, a testicular mass. A testicular mass typically is carcinoma. And if you do an FNA of a testicular mass, you're going to spread the cancer through the tract of the needle. With those 2 exceptions, you could do an FNA almost anywhere else. Well, an FNA here might be a good way to begin, but very often the pathologist needs more than a few cells, because lymphoma, after all, is a family of diseases. It's not just one. And it'd be probably necessary for the treating physician to know exactly the type of lymphoma in order to do the best treatment for it. Vignette number 6. A 72-year-old man has a 4 cm hard mass in the left supraclavicular area. The mass is movable, not tender, has been present for 3 months. The patient has had a 20-pound weight loss in the past 2 months, but is otherwise asymptomatic. You know this is metastatic cancer, but you don't look for the primary up in the head and neck. The primary is below the clavicles. A vignette like this on the exam might often come with enough indication as to where the primary is. Like it might be exactly what we read, plus the patient has been having blood in the urine, and now you're suspecting renal cell carcinoma. Or the patient has a testicular mass, and you are suspecting cancer of the testicle. Or the patient has been having epigastric pain straight through to the back, and you're suspecting pancreatic cancer. So that may be a hint, but if not, we can do an FNA, and we can, if needed, excise that node, either all of it or part of it, so the pathologist can look at the tissue and render a diagnosis. Let me now read vignette number 7. A 69-year-old man who smokes and drinks and has rotten teeth has a hard, fixed 4 cm mass in his neck. The mass is just medial and in front of the sternomastoid muscle, at the level of the upper notch of the thyroid cartilage. It has been there for at least 6 months, and it is growing. This is metastatic squamous cell carcinoma. The primary tumor is inside the head and neck, in the mucosa of the oropharyngeal laryngeal territory. Now, you could do an FNA of this mass. Remember, only a couple of contraindications for FNA, but please don't even think of doing an open biopsy. That would be an absolute no-no, because that incision you put on that mass interferes with the eventual operation that will need to be done for this, which perhaps would be better done through a different kind of incision. So this is an absolute no-no. The diagnosis should be established by looking inside for the primary. The procedure we use to do that is called a triple endoscopy or pang-endoscopy. The patient is anesthetized, the head is hyperextended with proper instrumentation. We look into the mouth, the pharynx, the nasopharynx, the larynx, the tracheobronchial tree, and the esophagus, looking for the primary, to biopsy the primary. If no primary is obvious, doing multiple biopsies in each of the areas that we are looking at. I might add that after a good many years of knowing that the old man who smokes and drinks and has rotten teeth is a candidate for this disease, we now recognize that younger patients who perhaps have never smoked or drank can also get this disease if they have AIDS. So we're now seeing a different type of patient with a squamous cell carcinoma. I still have to touch upon something else. Why is this? An old man who smokes and drinks and has rotten teeth. Smoking alone is an etiological factor for the development of a squamous cell carcinoma of the head and neck. Drinking alone is also a factor. But if you put the two together, they have a potentiating effect. It's more than additive. So the combination of drinking and smoking can lead very easily to squamous cell carcinoma. Now, the rotten teeth have nothing to do with the genesis of the tumor. They simply speak of a certain lifestyle. People who drink excessively and smoke all the time are not typically the kind of persons who are flossing their teeth constantly and having beautiful and shiny. So when we see these patients, we often find the rotten teeth. Well, now that we have talked about that particular condition, let's talk about other ways in which this type of cancer could present. And then we'll look at some decision trees. Let me read vignettes 8, 9, 10, and 11, and then we'll go to a decision tree. A 69-year-old man who smokes and drinks and has rotten teeth, has hoarseness that has persisted for 6 weeks in spite of antibiotic therapy. The squamous cell carcinoma is in the vocal cords. A 69-year-old man who smokes and drinks and has rotten teeth has a painless ulcer in the floor of the mouth that has been present for 6 weeks and has not healed. That is the primary tumor. A 23-year-old man with AIDS has a painless ulcer in the floor of the mouth and has been present for 6 weeks and has not healed. He doesn't smoke, he doesn't drink. That is also a squamous cell carcinoma. And a 69-year-old man who smokes and drinks and has rotten teeth has a unilateral earache that has not gone away in 6 weeks. Physical examination shows serous otitis media on that side, but not on the other. He probably has a tumor blocking the eustachian tube. Remembering all of these, you want to do the triple endoscopy or panendoscopy, the biopsies that way, eventually a CT scan to see the extent of the disease, and the therapy is usually multimodal. Surgery plus radiation plus platinum-based chemotherapy. Let's cut away from my face now and look at some of these issues again. So you might have a question on the exam dealing with a neck mass. If it is a young patient, the mass has been asymptomatic for many years, it is congenital. If it's in the midline at the level of the hyoid bone, it is a thyroglossal duct cyst. If it is in front of and under the sternomastoid muscle, it is a branchial cleft cyst. If it is in the supraclavicular area and mushy, it is a cystic hygroma. If the mass has been relentlessly growing for a few months, it is neoplastic. Let's continue. If it is a young patient, multiple enlarged nodes, low-grade fever, night sweats, it's a lymphoma. If it is a supraclavicular node, it is a metastasis from a primary whose location is below the clavicle. If it is on the side of the neck, in an old man who smokes and drinks and has rotten teeth, it's metastasis from a squamous cell carcinoma of the mouth, pharynx, or larynx. And this is the end of the neck masses.